Welcome back to Bookfulness. This is our sixth deep dive. Last time, we wrapped up the back, didn't we? Looking at its muscles, the contents of the vertebral canal, all about stability, really.
Yeah, the axial skeleton holding everything upright and protected. Solid stuff.
Exactly, but now we're doing a complete pivot, aren't we?
A huge pivot. We are diving into Chapter 3 of Moore's Clinically Oriented Anatomy, ninth edition, the upper limb. This covers pages 304 right through to 334.
So the arm, the shoulder, the hand, all of it.
Well, today we're laying the foundation. Our mission is to get a really solid overview of the upper limb's framework. We're talking about its bones, the superior appendicular skeleton, its major segments, and crucially, the fascial organization.
The fascia, right, that connective tissue that wraps and divides everything up.
Precisely. It's fundamental to how the limb is structured and how it functions. We need to understand that bony framework first, though.
Okay, I think this shift itself is fascinating. From the spine built for stability, protection to the upper limb, which seems designed almost purely for dexterity, movement.
That's a perfect way to put it. It's a classic evolutionary trade-off. We're leaving behind the weight-bearing stability focus of the back and, well, the lower limbs too, and embracing incredible mobility.
So let's unpack this superior appendage. What's its main job? What's the design philosophy here?
Fundamentally, the upper limb is all about mobility. Its primary function is positioning the hand. Think about it. Everything the arm and shoulder do is ultimately to get the hand where it needs to be for manipulation.
Right, whether that's intricate work like writing or, big powerful movements like throwing something.
Exactly. Typing, painting, climbing, reaching. The hand is the effector, the tool. The rest of the limb is this incredibly dynamic, adaptable system, a mobile strut, essentially to place that tool effectively in three-dimensional space.
And the skeleton that supports this, you called it the superior appendicular skeleton. It includes the shoulder girdle, too.
Yes, the superior appendicular skeleton comprises the pectoral girdle, that's the clavicle and scapula, and then the bones of the free limb itself, the humerus, radius, ulna, and the hand bones.
And you mentioned something crucial earlier, how it connects to the trunk. It's surprisingly minimal, isn't it?
It's astonishingly minimal, really. The entire weight and structure of the upper limb hang off the axial skeleton, the trunk, at basically a single, relatively small point.
Just one bony connection.
Just one true synovial joint articulation, the sternoclavicular joint, or SC joint. That's where the medial end of the clavicle meets the sternum. That's it.
Wow. So the scapula, the shoulder blade, it's not directly fixed to the ribs?
Nope. The scapula essentially floats. It's held in place and moved by a complex sling of muscles against the posterior thoracic wall. This lack of direct bony fixation is the key to the shoulder's incredible range of motion. It adds another whole layer of mobility.
If it were fixed, like, say, the pelvis is to the sacrum, we wouldn't have nearly the same reach.
Not even close. We wouldn't be able to raise our arms fully overhead. That floating scapula is critical.
Okay, so we've got this highly mobile limb connected minimally. How do we break it down functionally? Let's talk segments, maybe using figure 3.1 as a guide, proximal to distal.
Sounds good. So 4 major segments. First up, the shoulder. This is the region connecting the limb to the trunk. It includes the pectoral girdle bones, clavicle and scapula, and the proximal end of the humerus. It's the base of operations.
Okay, the shoulder.
Then we move distally to the arm proper. The term arm in anatomy, or brachium, specifically refers to the segment between the shoulder joint and the elbow joint. It contains just one bone, the humerus.
Got it. Arm equals humerus region. Next.
The forearm, or antebrachium. This runs between the elbow and the wrist. And here we have that characteristic two-bone structure, the radius and the ulna, parallel bones.
And finally, the business end.
Exactly. The hand, or manus, everything distal to the wrist joint. This includes the carpal bones forming the wrist, the metacarpals in the palm, and the phalanges, which are the finger bones. A really complex arrangement down there.
Shoulder, arm, forearm, hand. Makes sense. And figure 3.2 shows corresponding regions, right? More for surface anatomy.
Yes, the regions help us relate the deeper structures to what we can see or feel on the surface. Useful clinically. We talk about the pectoral region anteriorly, over the chest muscles connecting to the limb.
And the scapular region posteriorly, over the shoulder blade.
Right. Then the deltoid region, which is that curved cap over the shoulder joint itself, formed by the deltoid muscle. Deep to that, under the arm, is the axilla of the armpit.
Then down the limb?
We have the brachial region, corresponding to the arm segment, the cubital region around the elbow, particularly the anterior fossa. The adbrachial region is the forearm. And then the hand breaks down further into carpal wrist, metacarpal, palm, and digital fingers regions. It's a logical map.
Okay, now let's revisit that comparison you mentioned earlier, upper limb versus lower limb. You said it highlights the design priorities.
It really does. It's the classic anatomy comparison. Mobility versus stability. The upper limb is fundamentally designed for mobility, dexterity, manipulation. It sacrifices inherent stability to achieve that incredible range of motion.
Whereas the lower limb,
The lower limb is all about stability and weight bearing. It has to support the body's weight against gravity and provide a stable base for locomotion, walking, running, standing. Its design reflects that priority.
and the connection to the axial skeleton is the prime example.
Absolutely. We just talked about the upper limb's single small SC joint connection. Think about the lower limb's connection. The pelvic girdle, two large hip bones, is fused anteriorly at the pubic symphysis, and crucially, posteriorly, it forms massive, strong, relatively immobile sacroiliac joints with the sacrum.
Creating a solid, stable ring.
The very strong bony ring. It's built to transmit huge forces between the legs and the spine. Compare that robust fusion to the flimsy SC joint and the floating scapula. It's night and day. The shoulder girdle is built for freedom, the pelvic girdle for power and load transmission.
So stability comes from strong bony connections. Mobility comes from minimizing those connections.
That's the essence of it.
Yeah.
And it extends to the bones themselves. If you look at the overall plan, like in figure 3.3, both limbs follow a pattern.
Right.
One proximal bone, then two distal bones.
Humerus in the arm, femur in the thigh, then radius ulna in the forearm, tibia fibula in the leg.
Exactly. But how that two-bone unit functions is different, reflecting the limb's overall goal.
How so? In the forearm, you mentioned the radius and ulna allow rotation, pronation, and supination.
Yes, the radius is designed to pivot, to rotate around the more fixed ulna. This crossing over movement lets you turn your palm down, pronation, or up supination, without having to rotate your entire arm at the shoulder. It's crucial for fine motor control, using tools, eating, countless actions.
And the tibia and fibula in the leg, they don't rotate like that.
Not in the same way, no. There's a little bit of movement possible between them, especially near the ankle, but they primarily act as a solid, stable unit for weight bearing. The tibia is the main weight-bearing bone. The fibula is more slender, mainly serves as a site for muscle attachments, and importantly forms the lateral part of the ankle joint, the lateral malleolus, providing stability there. But it's not designed for the kind of functional rotation we see with the radius. Stability is the priority.
So same blueprint, one bone, then two, but adapted for different primary functions. Rotation in the forearm, stability in the leg.
Precisely. The upper limb is engineered for the hand. Flexible connections, rotating forearm bones, shallow joints, all maximizing the hand's working space, even if it means the shoulder, for example, is inherently less stable.
Which means muscles have to play a huge role in stabilizing it.
A massive role, especially the rotator cuff muscles around the shoulder. They provide the dynamic stability that the bones and ligaments alone can't offer. We'll definitely get into those later.
Okay, let's dive into the bones themselves, starting with that pectoral girdle, the foundation. First up, the clavicle, the collarbone. It looks quite simple, but you described it as an S-shaped strut.
It does look simple, lying just under the skin, but it's structurally quite sophisticated. It's a long bone, yes, but oriented horizontally. And its most defining feature is that double curve in the horizontal plane. It's not straight.
How does the curve run again?
The medial two-thirds the part closer to the sternum is convex anteriorly. It curves forwards. Then the lateral third, the part towards the shoulder point, flips its curve and is concave anteriorly, curving backwards. You can feel this S shape if you palpate your own clavicle.
And this shape isn't just for looks.
Definitely not. That double curve significantly increases its strength and resilience, like a spring-absorbing shock. It makes it much better at resisting compressive forces than a simple straight rod would be. Its main job is to act as a strut.
A strut? Holding what?
Holding the scapula, and therefore the entire arm, laterally and slightly posteriorly, away from the rib cage. It keeps the upper limb clear of the trunk, allowing it to swing freely. Without the clavicle, your shoulder would slump downwards and inwards. It maintains the width of the shoulder.
Okay, let's look at its ends, thinking about those connections again. Figure 3.4 shows the details. Medial end versus lateral end.
Right. The medial end is the sternal end. It's noticeably enlarged, almost triangular or quadrilateral in shape. This is the end that articulates with the manubrium of the sternum at that crucial SC joint we talked about. This is the anchor point to the axial skeleton.
And the lateral end.
The lateral third of the clavicle flattens out considerably. The acromial end is flat and articulates with the acromion process of the scapula. That's the AC or acromioclavicular joint. So a robust anchor medially and a more mobile, flatter connection laterally to the scapula.
Its shape, its position right under the skin. It seems built to be broken. Which brings us to the clinical highlight. Clavicle fractures, super common, right?
Extremely common. Probably the most frequently fractured bone in the body, especially in kids and young adults. Usually happens from falling on an outstretched hand, the force transmits up the limb, or falling directly onto the point of the shoulder.
And the break usually happens at a specific spot.
Yes, the weakest point structurally is the junction between the middle and lateral thirds, right where that S-curve changes direction. That's where most fractures occur.
But the key clinical thing here isn't just that it breaks, but how the pieces move afterwards, the displacement pattern. Muscles pull the fragments out of alignment.
Exactly. Understanding the muscle attachments is key to understanding the deformity you see. When the clavicle snaps, let's say at that junction, the two fragments are pulled in different directions by opposing muscle forces.
Okay, what happens to the medial fragment, the one still attached near the sternum?
That medial fragment gets yanked upwards, superiorly. Why? Because the powerful sternocleidomastoid muscle, which attaches to the superior surface of the medial clavicle, contracts and pulls it strongly upwards, and there's no counteracting force once the strut is broken.
So medial part goes up. What about the lateral fragment, the one attached out towards the shoulder?
That lateral fragment does a couple of things, usually simultaneously. First, it drops down, inferiorly. This is mainly due to the simple unsupported weight of the entire upper limb. The trapezius muscle, which normally helps support the shoulder girdle, attaches to the lateral clavicle, but once the bone is broken, the trapezius can't effectively hold up that weight against gravity.
It just sags down.
It sags. And second, it often gets pulled medially towards the midline. This is due to the pull of muscles that adduct the arm, like the pectoralis major. They try to stabilize the limb, but in doing so, they pull that lateral fragment inwards.
So the lateral piece drops down and pulls in, while the medial piece goes up. They must override each other.
They frequently do. The lateral fragment often gets pulled underneath the elevated medial fragment. This results in a noticeable shortening of the clavicle, a visible bump or deformity at the fracture site, and the patient typically supports the injured limb with their other hand to try and take the weight off.
Makes sense why they instinctively cradle the arm.
The internal muscles just can't cope without that intact bony strut.
The source also mentions the coracoclavicular ligament. How does that fit into this fracture scenario? It seems important for stability even when the bone breaks.
Ah, yes, the coracoclavicular ligament is incredibly important. It's actually two parts, the trapezoid and conoid ligaments running from the coracoid process of the scapula up to the underside of the lateral clavicle. It's exceptionally strong.
Stronger than the bone itself sometimes?
Often, yes. In many clavicle fractures, especially those just medial to the ligament's attachment, the coracoclavicular ligament remains intact. This is crucial because it acts like a strong tether, preventing the scapula, and thus the acromion, from displacing significantly inferiorly relative to the clavicle.
So even if the clavicle breaks, this ligament stops the AC joint from completely dislocating or separating.
Exactly. It maintains the relationship between the scapula and the clavicle, preventing a much more severe shoulder disruption, even with a bad clavicle fracture. It's a vital stabilizer.
Okay, that covers the strut. Now for the other half of the pectoral girdle, the scapula. The shoulder blade, you called it the mobile base.
That's a good description. The scapula is a large, mostly flat, triangular bone. It doesn't sit flat, though. It rests on the curved posterior surface of the rib cage, typically overlying ribs 2 through 7. Its primary role isn't static support, but dynamic movement.
It moves on the rib cage.
Yes, it glides and rotates across the thoracic wall. This movement is essential for increasing the overall range of motion of the arm. Think about reaching straight up. A lot of that movement isn't just at the shoulder joint itself, but also the upward rotation of the entire scapula. This coordinated movement is called scapulohumeral rhythm.
Fascinating. Okay, let's look at its features using figure 3.5. Lots of bumps and hollows for muscles. The fossa.
Absolutely. The posterior surface is dominated by a prominent ridge running across it that's the spine of the scapula. The spine divides the posterior surface into two depressions, or fossa. Above the spine is the smaller supraspinous fossa. Below the spine is the much larger infraspinous fossa.
And these house muscles.
Key rotator cuff muscles. The supraspinatus muscle originates from the supraspinous fossa, and the infraspinatus muscle from the infraspinous fossa.
Okay, that's the back. What about the front surface, the one facing the ribs?
That's the costal surface. It's concave and forms the large, shallow subscapular fossa. This is the origin for the subscapularis muscle, another major rotator cuff muscle. So the shape of the bone directly relates to these critical stabilizing muscles.
And that spine we mentioned, it doesn't just end, does it? It extends laterally.
Correct. The spine continues laterally and superiorly, flattening out to become the acromion. The acromion is that palpable bony point at the very top outer edge of your shoulder. It arches over the shoulder joint itself and is the place where the scapula articulates with the acromial end of the clavicle at the AC joint.
Got it. And there's another prominent process sticking out forwards.
Yes, projecting sort of supero-anteriorly like a bent finger pointing forward is the coracoid process. The name comes from Greek korax, meaning raven, supposedly resembling its beak. It lies just inferior to the lateral part of the clavicle.
And it's important for attachments.
Very important. It's the attachment point for that strong coracoid-clavicular ligament we just discussed, anchoring the clavicle. It's also the attachment site for several muscles, including the short head of the biceps brachii, coracobrachialis, and pectoralis minor. It acts as a stable anchor point.
Okay. What about the edges and corners, borders and angles? Useful landmarks.
Definitely useful for orientation and palpation. The scapula is roughly triangular. It has a superior border, which is the shortest and thinnest. Near the coracoid process, this border has a distinct notch, the suprascapular notch.
A notch for something to pass through?
Yes, the suprascapular nerve passes through, or sometimes over, this notch. Then there's the medial border, also called the vertebral border, which runs roughly parallel to the vertebral column, and the lateral border, or axillary border, which is thicker and runs downwards towards the armpit.
And where these borders meet, we have the angles.
3 angles. The superior angle is where the superior and medial borders meet. The inferior angle is where the medial and lateral borders meet. This is the most pointy inferior part of the scapula, and it's usually quite easy to palpate, especially if you ask someone to reach behind their back. It typically lies around the level of the T7 vertebra.
And the third angle, the lateral one.
The lateral angle is the most functionally significant. It's thicker and broader because this is where the glenoid cavity or glenoid fossa is located. This is the actual socket part of the shoulder joint.
The socket that articulates with the humerus, you mentioned it's shallow.
Extremely shallow. It's often described as pear-shaped, and it's much smaller than the head of the humerus it receives. Think less of a deep cup and more of a slightly indented plate. Maybe only a quarter or a third of the humeral head is actually in contact with the glenoid cavity at any given time.
Which brings us back to that mobility versus stability trade-off.
Precisely. This incredibly shallow socket is a major reason why the shoulder joint, the glenohumeral joint, has such a phenomenal range of motion. It allows the humeral head to glide and roll extensively. But the flip side is inherent instability.
Making it prone to dislocation.
Exactly. The glenohumeral joint is the most commonly dislocated major joint in the body, purely because of this bony architecture. Stability doesn't come from the bone fit.
It has to come from the soft tissues around it, ligaments, capsule, and especially muscles.
Absolutely. The joint capsule and ligaments provide some static stability, but the real key is dynamic stability provided by the muscles that cross the joint, particularly that group we keep mentioning, the rotator cuff muscles, supraspinatus, infraspinatus, caries minor, and subscapularis, often remembered by the acronym SITX.
How do they stabilize it?
Their tendons blend with the joint capsule, and they actively pull the large humeral head into the shallow glenoid cavity, compressing the joint surfaces together. They act like dynamic ligaments, constantly adjusting tension to keep the joint centered and stable throughout its wide range of movement, especially during forceful activities or when carrying weight. Without strong, coordinated rotator cuff function, the shoulder would be incredibly unstable.
Okay, let's move out from the girdle into the free limb itself, starting with the arm bone, the humerus. The single bone of the brachium, big bone.
It's the largest bone in the upper limb, acting as the main lever. Let's start at the top, the proximal end, which forms the shoulder joint. The most obvious feature is the large, smooth, hemispherical head of the humerus. This is the ball part of the ball and socket glenohumeral joint.
And just below the head, there are those necks we need to distinguish, anatomical versus surgical.
Yes, this is a really important distinction clinically. The anatomical neck is the slight constriction or groove that runs obliquely around the base of the head, separating it from the rest of the proximal end, specifically from the tubercles. This marks the line where the joint capsule attaches.
Okay, that's the anatomical neck. What about the surgical neck?
The surgical neck isn't really an anatomical feature in the same way. It's more of a clinical landmark. It's the narrower region of the humerus distal to the head and the tubercles. It's called the surgical neck simply because this is a very common site for fractures, especially in older individuals with osteoporosis. These fractures often require surgical repair.
Makes sense. And you mentioned tubercles just now, bumps near the head.
Yes, there are two prominent bumps just distal to the anatomical neck, serving as major muscle attachment sites.
Mm-hmm.
Laterally, there's the larger greater tubercle. Anteriorly and slightly medially is the smaller, lesser tubercle.
And these are for those rotator cuff muscles again.
Exactly. The greater tubercle is the insertion point for three of the four S-sits muscles. Supraspinatus on its superior facet, infraspinatus middle facet, and teretes minor inferior facet. The lesser tubercle is the insertion site for the fourth rotator cuff muscle, the subscapularis. So these tubercles are critical for shoulder movement and stability.
And there's a groove between them.
Yes. Separating the greater and lesser tubercles is a distinct vertical groove called the intertubercular sulcus. It's also commonly known as the bicipital groove,
Why bicipital groove?
because the long tendon of the biceps brachii muscle runs right through this groove. The tendon comes up from the forearm, passes over the humeral head, and attaches inside the shoulder joint on the scapula. This groove guides and protects the tendon. There's also a ligament, the transverse humeral ligament, that bridges the gap between the tubercles, holding the tendon in place within the sulcus.
Okay, moving down the shaft of the humerus, what are the key features there?
The shaft is roughly cylindrical proximally, becoming more triangular in cross-section distally. About midway down the lateral surface, there's a roughened, often V-shaped area called the deltoid tuberosity. As the name suggests, this is where the powerful deltoid muscle inserts.
The muscle that gives the shoulder its rounded contour?
That's the one. And then on the posterior aspect of the shaft, there's another really important feature, the radial groove, also called the spiral groove. It runs obliquely downwards and laterally across the back of the humerus.
A groove for the radial nerve.
Precisely. The radial nerve, along with the deep brachial artery, profunda brachial artery, lies directly within this groove, quite close to the bone. This is clinically significant because a fracture of the humeral shaft, particularly in this midregion, can easily damage or sever the radial nerve.
And that would have serious consequences.
Very serious. The radial nerve supplies the extensor muscles of the forearm and hand. Damage here typically leads to wrist drop, where the person can't extend their wrist or fingers, along with sensory loss on the back of the hand.
So, fracture location matters hugely for potential nerve injury. Surgical neck fracture risks the axillary nerve. Mid-shaft fracture risks the radial nerve.
You've got it. The axillary nerve wraps around the surgical neck to supply the deltoid. The radial nerve hugs the posterior shaft in that groove. Knowing this neurovascular anatomy relative to the bone is essential for diagnosis and treatment planning after a fracture.
All right, let's travel down to the distal end of the humerus, the elbow region. Figure 3.6 shows this complex area, the condyle.
The distal end flares out significantly to form the humeral condyle, which has the articular surfaces for the elbow joint. It's complex because it has to articulate with two different forearm bones.
The radius and the ulna.
Correct. On the lateral side of the condyle is the rounded, knob-like capitulum, Latin for little head. This articulates with the head of the radius. Medial to the capitulum is the trochlea, Latin for pulley. This is shaped more like a spool or pulley wheel, and it fits snugly into a corresponding notch on the ulna.
So capitulum for radius, trochlea for ulna.
That's the pairing. Flanking these articular surfaces are two non-articular bony prominences, the epicondyles.
The bumps you can feel on either side of your elbow.
Exactly. The medial epicondyle is the larger, more prominent one on the inside of the elbow. The lateral epicondyle is smaller on the outside. These are major attachment points for forearm muscles.
Which muscles attach where?
Generally speaking, the medial epicondyle is the common origin for the flexor muscles of the forearm, muscles that bend the wrist and fingers. The lateral epicondyle is the common origin for the extensor muscles of the forearm, muscles that straighten the wrist and fingers. This is why you get golfer's elbow, medial epicondylitis, or tennis elbow, lateral epicondylitis, inflammation at these muscle origins.
And the medial epicondyle has another claim to fame, the funny bone.
Ah, yes. The ulnar nerve passes in a groove directly behind the medial epicondyle. It's very superficial here, just under the skin. Hitting this spot compresses the nerve against the bone, causing that tingling electric shock sensation down into the forearm, and little finger, the funny bone feeling. It's not funny when it gets injured, though.
Right. Lastly, at the distal end, there are those depressions, the fossa, that receive parts of the forearm bones during movement.
Yes, 3 fossa accommodate the forearm bones at the extremes of motion, allowing a greater range. Anteriorly, directly above the trochlea, is the coronoid fossa. When you fully flex your elbow, the coronoid process of the ulna fits into this fossa.
Okay. And next to it?
Lateral to the coronoid fossa above the capitulum is the smaller radial fossa. This receives the edge of the head of the radius during full elbow flexion.
And on the back.
On the posterior side, there's a much larger, deeper depression called the olecranon fossa.
Mm.
When you fully extend your elbow, straighten your arm, the olecranon process of the ulna moves into this fossa. This deep fossa is what prevents the elbow from hyperextending. These fossae essentially define the bony limits of elbow flexion and extension.
Let's quickly touch on those humerus fractures again. The clinical box mentions 3 common types with different causes and effects. Surgical neck.
Right, surgical neck fractures, as we said, common in the elderly, often from a fall on the hand. They're frequently impacted fractures, meaning one bone fragment is jammed into the other. This can sometimes provide some stability, but the big risk here is damage to the axillary nerve and the posterior circumflex humeral artery, which run close to the surgical neck. Axillary nerve damage affects the deltoid muscle, causing problems with arm abduction.
Okay. Then the transverse shaft fracture. Different forces involved there.
Yes, a transverse shaft fracture, often from a direct blow. Here, the displacement depends on where the fracture occurs relative to the deltoid insertion. If it's distal to the deltoid insertion, the powerful deltoid pulls the proximal fragment outwards, laterally. The muscles lower down, like biceps and triceps, tend to pull the distal fragment upwards, leading to shortening and overriding. And of course, the radial nerve is at high risk in the radial groove with these mid-shaft fractures.
And the third one sounded particularly nasty, the intercondylar fracture.
It is nasty. An intercondylar fracture usually results from a severe fall directly onto a flexed elbow. The force drives the pointy olecranon process of the ulna upwards, like a wedge, right between the two condyles, capitulum and trochlea, of the humerus.
For splitting them apart.
Exactly. It splits the capitulum and trochlea from each other and from the main shaft of the humerus. It essentially shatters the distal end. These are complex intra-articular fractures, very unstable, and almost always require significant surgical reconstruction, or IF, open reduction, and internal fixation.
Okay, moving down from the humerus to the forearm, we have the ulna and the radius, that 2-bone unit. You emphasized their role in pronation and supination.
Yes, having 2 parallel bones connected by an interosseous membrane is the key structural arrangement that allows for this rotation. But the ulna and radius themselves are specialized for different roles within that partnership. The ulna is more about stability at the elbow, while the radius is more about rotation and the wrist connection.
Let's focus on the ulna first, the stabilizing bone, especially its proximal end, right? Figure 3.7 shows it well.
Exactly. The proximal ulna is thick, strong, and uniquely shaped to provide stability at the elbow. It's dominated by 2 large processes. Posteriorly, the prominent olecranon, that's the bony point of your elbow that you can easily feel. Anteriorly, projecting forwards, is the coronoid process.
And together they form a C shape.
Yes. These 2 processes together form the large, C-shaped trochlear notch. This deep notch grips the trochlea of the humerus like a wrench fitting onto a nut. This tight interlocking articulation is what makes the elbow primarily a hinge joint, allowing flexion and extension but very limited side-to-side movement. There's also a small notch on the lateral side of the coronoid process, the radial notch, where the head of the radius articulates, allowing rotation.
So massive and stable proximally, what happens distally?
The ulna tapers significantly as it goes down the forearm. Its distal end is much smaller and consists of a rounded head of the ulna and, projecting medially and slightly posteriorly from the head, a small pointed bump called the ulnar styloid process. You can feel this styloid process on the medial little finger side of your wrist.
Okay, so the ulna is big proximally, small distally. Now the radius, the rotator, is it the opposite?
Pretty much the opposite structure, yes. Proximally, the radius is relatively small. It starts with the disc-shaped head of the radius. This head is concave on top to articulate with the capitulum of the humerus, and its rim articulates with the radial notch of the ulna. This allows it to spin during pronation-supination.
Below the head.
Just distal to the head is the constricted neck of the radius, and then below that, on the anteromedial side, is a prominent oval bump called the radial tuberosity. This is a really important attachment site.
For which muscle?
The main tendon of the biceps brachii muscle inserts here. The biceps is a powerful flexor of the elbow, but also a very powerful supinator of the forearm, and this tuberosity provides strong leverage for that action.
So small head for rotation, tuberosity for biceps. What about the shaft and distal end?
The shaft of the radius gradually widens as it goes distally. Unlike the ulna, the distal end of the radius is large and broad. This expanded distal end forms the main articulation with the carpal bones for the wrist joint. It bears most of the force transmitted from the hand.
And it has a styloid process, too.
Yes, on its lateral side, the distal radius projects downwards as the prominent radial styloid process. This is larger and extends further distally than the ulnar styloid process. You can palpate it on the thumb side of your wrist. It provides lateral stability to the wrist joint.
So figure 3.8 really highlights that contrast. Ulna is the main bone forming the elbow joint proximally, while the radius is the main bone forming the wrist joint distally.
That's the perfect summary. Ulna, elbow stability. Radius, wrist articulation, and forearm rotation. They work together, connected by that strong interosseous membrane running between their shafts, which helps transmit forces and provides surface area for muscle attachments, but their primary roles at the proximal and distal joints are quite distinct.
Let's quickly cover the clinical highlight for the ulna, fracture of the olecranon. The fractured elbow, you mentioned it's often an avulsion fracture?
Yes, it's a classic avulsion fracture. It typically happens from falling directly onto the point of the elbow, often combined with a sudden, forceful contraction of the triceps brachial muscle trying to break the fall.
And the triceps attaches right on to the olecranon.
Exactly. The powerful triceps tendon inserts onto the superior surface of the olecranon. When the fracture occurs, the strong pull of the contracting triceps muscle literally avulses or pulls the olecranon fragment away from the rest of the ulna, often displacing it significantly proximally upwards.
And because the triceps is always pulling on it, just putting it in a cast doesn't work well.
Generally not for displaced fractures. The constant tension from the triceps keeps pulling the fragment away, preventing the bone ends from staying aligned for healing. That's why these fractures often require surgery, typically tension band wiring or plating, where wires or a plate and screws are used to physically pull the fragment back down, hold it in place, and counteract the triceps pull while the bone heals. It's another great example of how muscle forces dictate fracture treatment.
All right, we've made it down the limb to the hand itself. Complex structure here, starting with the wrist bones, the carpals. 8 small bones, arranged in rows. Figure 3.9 is key here.
Yes, 8 small, irregularly shaped carpal bones make up the carpus, or wrist. They are arranged more or less into 2 rows of 4 bones each. They form a flexible unit that allows some movement between the forearm and the hand and provides a stable base for the metacarpals.
Naming them in order is apparently a rite of passage for anatomy students.
Let's do it. Lateral to medial, so thumb side to little finger side, starting with the proximal row, the one closer to the forearm. Okay, proximal row, lateral to medial. First is the scaphoid. It's somewhat boat-shaped. Scaphoid means boat in Greek. And it's important because it articulates directly with the radius. Next to it is the lunate, which is moon-shaped or crescent-shaped and also articulates with the radius.
Scaphoid, lunate.
And the triquetrum, which is roughly pyramidal or three-cornered, and sitting right on the palmar anterior surface of the triquetrum, like a pea on a platform, is the tiny pisiform. The pisiform is actually a sesamoid bone embedded within the tendon of the flexor carpi ulnaris muscle.
Okay, SLTP. Scaphoid, lunate, triquetrum, pisiform. Now the distal row, again, lateral to medial.
Distal row, starting on the thumb side again. The trapezium. It's 4-sided and has a distinctive saddle-shaped facet for articulating with the thumb metacarpal, allowing the thumb's special movements. Next is the trapezoid, a smaller wedge-shaped bone.
Trapezium, trapezoid.
Then comes the largest of all the carpal bones, right in the middle, the capitate, which means head-shaped. And finally, on the medial side is the hamat, which is easily identified by a prominent hook-like projection on its palmar surface, the hook of the hamat.
So TTCH, trapezium, trapezoid, capitate, hamat, got it. You mentioned the scaphoid is important clinically.
Extremely important and unfortunately quite vulnerable. The scaphoid is the most commonly fractured carpal bone, typically from a fall onto an outstretched hand with the wrist extended, Farrosh injury. The problem isn't just the fracture itself, but its blood supply.
What's wrong with its blood supply?
The main arteries supplying the scaphoid typically enter the bone at its distal end or waist. If the fracture occurs across the waist of the scaphoid, the narrow middle part, the blood supply to the proximal fragment, the piece closer to the radius, can be completely cut off.
Leading to bone death.
Exactly, a vascular necrosis, AVN. The proximal fragment dies due to lack of blood, which means the fracture often fails to heal properly, non-union, or heals very slowly. This can lead to long-term wrist pain, arthritis, and loss of function. Scaphoid fractures need careful diagnosis and management because of this high risk of AVN.
And the hamat's hook, also vulnerable.
Yes, the hook of the hamate projects into the palm and can be fractured, often by direct impact or pressure, like gripping a golf club, tennis racket, or baseball bat tightly during a forceful swing. The handle impacts the hook.
And why is that hook important? Structures nearby.
Very important structures run right next to it. The ulnar nerve and ulnar artery passed just lateral to the hook through a space called Guyon's canal. A fracture of the hook, or even just chronic pressure here, can compress or damage the ulnar nerve, causing numbness, tingling, and weakness in the little finger and ring finger, and affecting some small hand muscles.
Okay. Distal to the carpals, we have the bones forming the palm and fingers.
Right. We have the 5 metacarpals. They're numbered 1 to 5, starting with the thumb, metacarpal 1, and ending with the little finger, metacarpal 5. They form the bony framework of the palm. Each metacarpal has a base, proximally articulating with carpals, a shaft, and head, distally, articulating with the phalanges to form the knuckles.
And then the fingers themselves, the phalanges.
The phalanges are the bones of the digits. Digits 2 through 5, index, middle, ring, little fingers, each have 3 phalanges. A proximal phalanx, articulating with the metacarpal head, a middle phalanx, and a distal phalanx, which supports the fingernail.
But the thumb is different.
The thumb, digit 1, is the exception. It only has 2 phalanges, a proximal phalanx and a distal phalanx. It lacks a middle phalanx. This difference contributes to the thumb's unique mobility and opposability.
The source also mentions using hand bone development to assess age, ossification centers.
Yes, particularly in children and adolescents. Bone development follows a predictable pattern. Different bones and different parts of bones, like the epiphyses, growth plates, begin to ossify, turn from cartilage to bone at specific ages.
So you can x-ray a child's hand.
Exactly. A radiograph of the hand and wrist shows the carpal bones and the epiphyses of the metacarpals and phalanges. By comparing the number and stage of development of these ossification centers to standardized charts, like the Grulich and Pyle Atlas, clinicians can determine the child's skeletal age or bone age.
And that's useful.
Very useful. Skeletal age can sometimes differ from chronological age and is often a better indicator of a child's overall physical maturity and remaining growth potential. It's used in endocrinology, pediatrics, and orthodontics.
Okay, now let's bridge the gap between the skeleton and the living person's surface anatomy. Being able to feel these bones is key for examination.
Absolutely fundamental. Palpation skills are crucial. Let's run through some key palpable landmarks, maybe referring to figures 3.10, 3.11, and 3.12. The clavicle is a great starting point because you can feel pretty much its entire length just under the skin, from the SC joint medially to the AC joint laterally.
And at the point of the shoulder.
You can feel the subcutaneous acromion process of the scapula forming the bony roof. Follow its lateral border posteriorly until you feel a distinct angle where it turns downwards. That's the acromial angle. It's a useful reference point.
How about finding the rest of the scapula on the back? It moves around.
It does move. The spine of the scapula is usually easy to feel running across the upper back, starting medially near the T3 vertebra and extending laterally to become the acromion. To feel the medial border, sometimes it helps to have the person place their hand behind their back, which makes the border wing out slightly. The inferior angle, the bottom tip, is often visible and palpable, usually around the T7 level when the arm is hanging down.
Okay, down at the elbow.
The medial and lateral epicondyles of the humerus are very prominent. The medial one is larger and easier to find. Remember, the ulnar nerve runs right behind it. You can also feel the olecranon process of the ulna very easily, the point of the elbow.
And the rest of the ulna.
The entire posterior border of the ulna is subcutaneous, running down the medial side of the forearm. You can palpate it all the way from the olecranon down to the wrist. It acts as a useful guide separating the forearm muscle compartments.
What about the distal ends at the wrist?
You can feel the small, rounded head of the ulna on the dorsal backside of the wrist, especially when the hand is pronated, palm down. Just distal to it is the point of the ulnar styloid process. On the lateral thumb side, the broader radial styloid process is palpable, extending further distally than the ulnar styloid. The anatomical snuff box depression on the back of the wrist is a good landmark for finding the scaphoid bone deep inside.
One bone that's hard to feel is the head of the humerus itself. It's deep.
It is quite deep, covered by the thick deltoid muscle and the rotator cuff. You can't really feel it well from the outside. The best way is to relax the arm, perhaps slightly abducted, and press your fingers deeply upwards into the axilla, armpit, below the deltoid. You might then feel the rounded head moving as the arm is passively rotated. But it's not an easy landmark to palpate clearly.
This discussion of deep structures naturally leads us to the fascia, the connective tissue that wraps and organizes everything.
Yes, fascia is critical. It's not just passive wrapping. It plays active roles in function, support, and pathology. We generally talk about 2 main layers. First, the subcutaneous tissue, also called superficial fascia. This is the loose connective tissue layer just beneath the skin, containing variable amounts of fat, superficial veins, lymphatic vessels, and cutaneous nerves.
And deep to that.
Deep to the subcutaneous tissue is the deep fascia. This is a much denser, stronger, membranous layer of connective tissue, devoid of fat. It invests the muscles, grouping them together, and also forms thicker sheets that divide the limb into compartments.
Let's look at the fascia in the proximal region first, near the shoulder and chest wall. Figure 3.13 shows this. It's quite complex here.
It is because it blends with the fascia of the trunk. Anteriorly, we have the pectoral fascia. This is a strong layer that encloses the large pectoralis major muscle. It's attached to the clavicle and sternum above, and inferiorly, it's continuous with the fascia of the anterior abdominal wall.
What about in the armpit region?
Laterally, the pectoral fascia becomes continuous with the axillary fascia. This forms the floor base of the axilla. It's thinner here, allowing for the mobility of the armpit region.
And deep to the pectoralis major, there's another layer.
Yes. Deep to pec major and its fascia is the clavipectoral fascia. This is an important sheet that descends from the clavicle, enclosing the small subclavius muscle just below the clavicle, and then splits to enclose the pectoralis minor muscle lower down.
This clavipectoral fascia has some specialized parts, doesn't it?
It does. The portion of the clavipectoral fascia between the subclavius muscle above and the pectoralis minor muscle below is thickened and called the costocoracoid membrane. This membrane is clinically important because it's pierced by structures passing between the axilla and the pectoral region, namely the cephalic vein, the thoracoacromial artery and vein, and the lateral pectoral nerve.
And below pectoralis minor.
Below the pectoralis minor muscle, the clavipectoral fascia continues downwards and fuses with the axillary fascia. A part of it here forms the suspensory ligament of the axilla. This ligament helps to support the floor of the axilla and pulls the skin upwards when the arm is abducted, creating the characteristic hollow of the armpit.
Okay, so complex fascia around the shoulder girdle connecting to the trunk. Now, what about the fascia in the free limb itself, the arm and forearm? Figure 3.14 illustrates the compartmentalization.
This is where the deep fascia becomes really important functionally. The arm is enclosed by a strong sleeve of deep fascia called the brachial fascia. It's continuous proximally with the pectoral, deltoid, and axillary fascia.
And it sends partitions inwards.
Yes, this is crucial. Extending inwards from the deep surface of the brachial fascia, like walls, are two strong sheets of connective tissue called the medial and lateral intermuscular septa. These septa attach directly to the medial and lateral supracondylar ridges and the shaft of the humerus.
And these septa divide the arm.
They effectively divide the arm into two distinct fascial compartments, an anterior or flexor compartment, and a posterior or extensor compartment. The anterior compartment contains the muscles that primarily flex the elbow, like biceps brachii, brachialis, coracobrachialis, and the musculocutaneous nerve. The posterior compartment contains the muscles that extend the elbow, triceps brachii, and the radial nerve.
This compartmentalization extends into the forearm, too.
Yes, the deep fascia of the forearm, the antebrachial fascia, similarly divides the forearm muscles into anterior flexor and posterior extensor compartments, although the arrangement is a bit more complex there with superficial and deep groups. The ulna, radius, and the interosseous membrane also contribute to this separation.
Why is this compartmentalization so clinically significant? You mentioned compartment syndrome earlier.
Because the deep fascia and the intermuscular septa are very tough and relatively inelastic. They don't stretch easily. This creates enclosed spaces, the compartments. While this is good for muscle efficiency, it becomes dangerous if there's significant swelling or bleeding within a compartment.
Like after a fracture or a crush injury?
Exactly. If pressure builds up rapidly inside a compartment due to swelling, edema, or bleeding hemorrhage, the unyielding fascia prevents the compartment from expanding. This rising pressure starts to compress everything within the compartment, especially the thin-walled veins first, then the arteries, and crucially, the nerves.
Cutting off blood flow and damaging nerves.
Precisely. This is compartment syndrome. It's a surgical emergency. Reduced blood flow, ischemia, can lead to muscle death, necrosis, and nerve damage within hours if the pressure isn't relieved. The treatment is usually a fasciotomy, where the surgeon makes long incisions through the skin and the deep fascia to open up the compartment and release the pressure. If it's not treated quickly, it can lead to permanent disability, like muscle contractures, for example, Volkmann's ischemic contracture in the forearm, and paralysis.
A stark reminder of how anatomy directly impacts clinical outcomes. But fascia isn't just about problems. It has positive roles, too, like helping blood return, the musculovenous pump.
Yes, this is a vital physiological function, especially in the limbs where blood has to travel back to the heart against gravity. The deep fascia, the intermuscular septa, and the contracting muscles within the compartments work together as a musculovenous pump.
How does that work?
When the muscles inside a fascial compartment contract, they bulge outwards. Because the deep fascia forms a tight restrictive sleeve around them, this outward bulge compresses the deep veins that run alongside or within the muscles.
Squeezing the blood in the veins.
Exactly. And because the deep veins in the limbs have numerous one-way valves, this compression forces the blood to move proximally towards the heart. When the muscles relax, the pressure drops, and the veins refill with blood from distal segments, ready for the next squeeze.
So muscle activity literally milks the venous blood upwards, valve by valve.
That's a perfect way to describe it. It's a milking action. This mechanism is essential for efficient venous return, preventing blood from pooling in the lower parts of the limbs, reducing edema, and helping overall circulation. The deep veins benefit greatly from this pump. Superficial veins lying outside the deep fascia rely more on gravity, residual arterial pressure, and adjacent muscle tone, but don't get the direct compressive benefit of the pump in the same way. It's a really elegant system using the existing anatomy for circulatory assistance.
So we've built the upper limbs framework today, from the single mobile anchor at the SC joint, emphasizing mobility over stability.
Right through the structure of the clavicle as a strut, the scapula is a mobile base, the humerus is the arms lever, and that crucial two-bone setup of the radius and ulna allowing rotation.
And finally, seeing how the deep fascia isn't just wrapping but actively compartmentalizes function, creates potential pathological spaces like in compartment syndrome, but also assists circulation via the musculovenous pump.
It all ties together. The shallow glenoid, the S-shaped clavicle, the radial head spinning on the capitulum, every detail serves that primary goal of positioning the hand with maximum dexterity and range. We saw the clinical implications too: nerve injuries tied to specific fracture sites, the risk of AVN in the scaphoid, anatomy dictating pathology.
A great foundation. So what's next? We have the scaffolding. Now we need to add the movers and the wiring.
Exactly. In our next deep dive, we'll start exploring the neurovasculature. The major nerves, like the brachial plexus branches, axillary, radial, musculocutaneous, median, ulnar, and the arteries supplying the limb. And we'll begin populating these fascial compartments we defined today by looking at the muscles, starting with those connecting the limb to the trunk, the pectoral and scapular region muscles.
Sounds good. Putting the flesh on the bones, quite literally.
We'll see how those muscles attach to the landmarks we discussed today and how the nerves control their actions.
Looking forward to it. Thanks for listening to Bookfulness.